Assalamu alaikum. Now, for covering the topics of endocrinology and infertility, I'd like to invite our respected chairpersons, Professor Azra Saeed Awan, Professor Azra Saeed Awan, Professor Azra Saeed is a senior gynecologist practicing in Rawalpindi. Our next chairperson, Dr. Kevin Artley. He is a consultant gynecologist at Concept Fertility Center, Australia. His special areas of interest are investigation and treatment of male and female infertility, laparoscopic surgeries, and reproductive endocrinology, including PCOS. Our next chairperson, Professor Farrukh Nahid. She is a competent and experienced gynecologist currently working at Zainab Medical Center. Moving on, I'd like to invite our respected speaker, Professor Jamel Ahmed, who is a professor and chairman at Buckeye Medical University. Please come to discuss hyperprolactinemia management with us.
Bismillahirrahmanirrahim. Bismillahirrahmanirrahim. First of all, I thank the organizer and my colleague, Professor Sadia, for inviting me for this talk. And I am pleased to be here as a clinician who is also practicing endocrinology in a very so far absorbing lecture and things which I have heard. Now, what I am going to discuss is so I have no conflict of interest. Now, what I am going to discuss is hyperprolactinemia and of course its management. So, as far as prolactin is concerned, a polypeptide 198 amino acid, it was discovered incidentally not in humans, in animals, and it was until 1970 it was located there. The importance of prolactin is that it comes and float in the body in 3 sizes, and that has created some problem as far as the management is concerned, because there is a smaller size molecule as far as prolactin is concerned and a macro prolactin is concerned, which has caused great difficulty as far as managing and the outcome is concerned. The half-life, as you can see, it's self-explanatory, you can read it, and it has got its own circadian rhythm. Now, what's the physiological mechanism that you can see? It all depends one important thing, that is the stimulation of the nipple. Although there are various factors, but this is the most important one. And that the signal, the pathway is important, that how the signal goes into the brain and eventually end up in hypothalamus. And in the hypothalamus, then the signal comes down into the area of the pituitary where the cells lies, which are responsible for production of prolactin. One thing very important to understand here at this diagram, that this is one thing important, and that is the flow of dopamine, the dopamine agonism. The dopamine agonism is an important stimulus as far as the production of prolactin is concerned, because the problem when it starts, which we are going to discuss in a little later, this is all about the activities as far as dopamine is concerned. Now, what are the clinical features? It's a big list, right? And in either sexes, things are different, but of course, you can have any spectrum as far as the menstruation is concerned. You can have amenorrhea, oligomenorrhea, menorrhagia, infertility, galactorrhea, vaginal dryness, irritability, headache, anxiety, and depression. The same one or two things in males: diminished libido, erectile dysfunction, infertility, gynecomastia, and headache. And there are things which are due to the tumors producing prolactin, that is prolactinoma. They usually cause mass effect, that is headache, and when they increase in sizes, we know that it's close proximity with the visual pathway. So, they put pressure on optic chiasma and that result in the visual field defect. Now, what is the etiology of hyperprolactinemia, that how it's going to happen now, and how its effect we will discuss in a minute. Now, this is in front of you the physiological causes: pregnancy, puerperium, suckling, nipple stimulation, and that stimulation, even if it is pathological thing, when there is surgery, as far as the chest is concerned, that is also there. So, as far as pathological things are concerned, the lists are there: prolactinomas, the top of that, and then we got hypothyroidism, a very, very important thing to understand whenever you are dealing with subfertility or infertility. We will talk about it in a minute. Then cirrhosis and kidney disease. Why cirrhosis and kidney disease? Because the prolactins metabolize through these two organs, and of course, they are defective. If they are not functioning properly, then you can have an imbalance as far as prolactin is concerned, and that result in subfertility or infertility. Then of course, acromegaly, a tumor which is of course pressurizing the whole of the pituitary, and all the hormones coming out of it, they are being affected, and of course, the prolactin level is also. So, there are things which you can see on this list, that it's a big list, and that put a lot of pressure, okay, because being practicing obstetrician, even the clinician endocrinologist, that if someone comes with subfertility or infertility, first to understand that how you are going to help him. So, that's a consideration is quite wide. Now, this is the huge problem here, and that huge problem is the drugs which are responsible for that. Now, this is the one point which is neglected as far as clinicians are concerned, and we do not go into the details as far as drug formulary which they are imbibing. Okay. At these stage, I mean, one of the study from America says that the leading cause of death is polypharmacy, that 30,000 people are dying of prescription, right. And now, if you can see at this list, that anything which is antagonizing dopamine, the huge list as far as all the antipsychotic, antidepressant, anxiolytics are concerned, you name it, you can get it here. Now, gone by the days when these drugs are used only for schizophrenia or severe depression or severe anxiety. At present, as a clinician, I know that when someone got dyspepsia, that is indigestion, the majority of the patient with indigestion or dyspepsia, they are functional. 75% to begin with. Now, at the moment, 80 to 85%, they have got upper GI symptom due to functional dyspepsia, and the best treatment is SSRI. And now, the patient is very comfortable with that, because dyspepsia, no ulceration, no gastritis, no GERD, nothing like that, and they are comfortable with that, and the counterproduction is that they are going to have a relative excess as far as prolactin is concerned, and eventually end up in infertility or subfertility. So, this is a big group of drug, and that should be part and parcel of our history taking, that any pharmacological agent which the patient is imbibing not affecting this hypothalamic, thalamic, and the body tree. Now, this is the latest one, that what is the prevalence of this. Now, the prevalence is 50 per 1,000, 100,000, and 3 to 5 new cases. Now, this is, I quoted the latest one, July 2019, and the basic problem what you have seen here in this paper, they have produced, that not only prolactinomas, the hyperprolactinemia induced gonadotrophin failure is there, and it's involved the cells which produce cells which are there up in the pituitary. And the prolactinomas in males are larger and more invasive, and macroprolactin is a very, very important point to understand, which can give a wrong diagnosis and hence the wrong management. Now, how to reach a diagnosis? I must emphasize here again that you will not be able to, or we will not be able to reach a diagnosis until unless we have taken a complete history. There is no term like a very good history, very nice history. History is a history, a complete history is a complete history. Okay? And if we have omitted one or two things, the habit of the patient and especially the history of drug imbibement, then perhaps we are going to miss the diagnosis. Now, once you are certain that there is a possibility that you might be dealing with that, and of course, the patient approach all of you, and people are referred to us from this problem, and sometimes we pick because some of the drug formulary which has been used is usually prescribed by the physician, clinician, endocrinologist, right. So, how to make a diagnosis after history and of course examination, then we go to this laboratory investigation, make sure that your patient is not pregnant. Thyroid function test is mandatory because hypothyroidism is a condition which is going to produce it and make the patient subfertile or infertile, and until unless you correct it, perhaps you are going in a wrong direction if you are correcting the prolactin level only. Then of course, you have to screen the kidney and the liver. So, there is no problem there because this is the route through which the prolactin is usually metabolized. And there are 2 or 3 other things which got to be tested like testosterone level, LH-FSH and estradiol, and of course, you go for serum prolactin. Now, serum prolactin is an important thing, and 1 or 2 things which I would like to say per se as far as the measurement of serum prolactin is concerned. It is customary that never ever rely on just one reading as far as serum prolactin is concerned. That is point number 1. So, you have to have 2 or 3 reading as far as serum prolactin is concerned. The other thing is that you got to be certain that you are not dealing with a macroprolactin. Macroprolactin is another problem, right, which not necessarily associated with subfertility or infertility, or even if it is associated with that, the management is different. As far as the prolactinomas is concerned, which is of course one of the things which is heading the hyperprolactinemia, you have to screen the pituitary and the whole brain. Remember that complete screening is necessary, and of course, fine details are needed. I have seen people requesting the CT scan, and of course, we do not see the fine anatomy as far as pituitary is concerned. So, because this sometimes the tumors are so small, so that only distinguishable by magnetic resonance imaging. Now, this is what I was talking about, and this is very well represented in this, self-explanatory. The two types of kit, 2 types of mechanism, and both giving altered result, not matching with each other. So, that is why it is important to understand what is the true prolactin level of the patient, because that is going to affect the management and of course, tells you where exactly you stand. Now, this is another important thing which I just discussed, that what is the importance of macroprolactin and how common it is. So, this is one paper which is produced here, right, published in Journal College of Physician and Surgeon, and you can see that in words very clearly they have mentioned that a significant number of patients, they have got macroprolactin, and of course, this management is totally different. So, just one reading is not enough to label a case a hyperprolactinemic and resulting in sub or infertility. Now, this is another study where the problem is pretty obvious. We all know that this hyperprolactinemia thing is underdiagnosed here, and it's often overlooked. It's often overlooked, okay? And perhaps I'll say that as a physician or clinician, I also take some responsibility for that, because we don't go into the details of that. And now this study clearly mentioned that you can see that how common it is. And the important thing is that once you realize that your patient is hyperprolactinemic, then of course you can solve the main concern of that patient. And this is what is the true state as far as in some of the other country in Pakistan, although I'll show some data on the world as well, but this very, very important consideration, you can see that. That's another area, hyperprolactinemia almost 17% infertility. Now, what's as far as male infertility is concerned? Because this is another thing, of course, it's in our society, it's rather difficult to pinpoint at male, and unfortunately, the female cannot pinpoint it. But what I have seen, you people, the expert on this field, knows more about it. But it often, the culprit is not female, is the male, and this is the one reflection of that. Now, once you reach a diagnosis, so if I just summarize that the patient presented to you has got problem, subfertility, infertility, you have taken a detailed history and you have made up your mind that this patient is not on any pharmacological agent which is going to increase the level of prolactin. And of course, you know that it's got a normal functioning liver and kidney and everything is fine. And then of course, you make one or two measurement of prolactin level, considering that macroprolactin is not the cause, and then you start thinking that how you're going to deal with this case. Now, any drug, the foremost thing which I have mentioned earlier, that got to be stopped. Even just stopping for 2 or 3 weeks, in some condition few days even, but 3 or 4 weeks, you can see that the normal axis is start working and eventually the problem is gone. Now, if the patient is hypothyroid, then you have to address that issue, because that is not going to, patient is not going to get better until unless thyroid status is okay. Again, first, as far as thyroid function test is concerned, of course, you going to have a detailed talk on that, but usually again in this one as well, that you get thyroid function test on at least 2 occasions and do estimate the free T3 and free T4 rather than the albumin bound T3 and T4. And then again, what is the management? Now, dopamine agonist, this is the cornerstone of the therapy. Time tested, proven, easy when you know the diagnosis, easy when you understand the patient, as simple as that. Now, the drug which is leading at the moment is cabergoline. It's not easily available in Pakistan, but it is, right? And there are plenty of literature available on this drug, which we see very shortly how it's given 0.25 milligram first week, and then you up it to twice a week, and then you gradually build it up to a maximum of 1.5 milligram twice. and all the time it is guided by prolactin level. Remember that you have to follow, otherwise you will perhaps overdo the things. Then the bromocriptin, well, bromocriptin is there for quite some time, and what I have seen, majority of the patient of hyperprolactinemia are usually prescribed bromocriptin. I also prescribe it because it's easily available, and but it is side effect profile of bromocriptin is far higher as compared to the other drug. So much so that all the authorities, all the paper and the recommendation at the moment is about that drug. And then we have quinabolide. It's not available in Pakistan. Even with difficulty, you're not going to get it unless you import it somewhere else. And it's available in Europe. It's even not available in United States of America. Now, this is as far as the drug therapy is concerned and how effective it is and what is the inference out of treating the patient with these. I'll show you in a minute. And then if you got prolactinoma, it's big enough, then you need to do surgery. You have to take that tumor out. And we know that for that transsphenoidal approach is used. But what are the indications that when you're going to go for it, right? Then we'll discuss. Now, this is self-explanatory. This is to begin with when people started comparing it. Now, CAB has left BRC with quite a distance. That's very, very effective. Now, this thing is going to be discussed later on. This another very important thing, that if you treat hyperprolactinemia, the physique of the patient, the look of the patient, the anthropometry is going to get better as well, and that is evidence based. Now, this is the study from Pakistan. The effectivity of both the drug. The only thing is that side effect profile of CAB is much better than bromocriptin. This is another important aspect, that even if you got a big prolactinoma responsible for hyperprolactinemia, then if you put the patient on medical treatment or medical therapy, not only that, you address the issue of infertility and subfertility, but the tumor size is also going to regress, and this is the evidence of that. So, another interesting thing which came out, that if the tumor, the prolactinoma, which is responsible for hyperprolactinemia, is relatively resistant to dopamine agonist, then if you can put the patient in conjunction with that, you will have a better result. You have another pointer because this one is not showing up in this digital screen. I'll draw your attention to this point. And this is, now you can see that the anatomy is returned to normal. So, you can easily, even in a bigger site tumor, put the patient on medical therapy, and you end up having patient, right, not only getting normalized the prolactin level, but the pressure effect of the tumor is going to go away. So, this is the recommendation now these days, right, that you go for it, right, until or unless with the passage of time the patient's pressure symptom is not going to get better. This issue is important, that how long you going to persist with. Now, this issue addressed by this team, and they come up with the evidence based thing that you start tapering it off after 2 years, and then when the prolactin level is static within the acceptable limit, then you can take it off, as long as there is not a big tumor, which I have just shown in the previous slide. So, this is an important thing, that how long you are going to go for it as far as the drug treatment is concerned. So, this issue was addressed in this paper, and this is evidence based. Now, this is important for you people. What they have documented here, that if you are going to go for this ICSI, egg retrieval and all that, egg transfers, and you kept on treating the prolactin level as well, even if it is slightly disturbed, is not going to get, it's not going to have a strong impact as far as your treatment is concerned. And having said that, even when you treat hyperprolactinemia with the drug, even after having this strategy as far as the treatment of fertility is concerned, you can have a successful event. This is one thing which we got to be aware of, that there is, when, because we do a hormonal analysis in every stage and every aspect, you people being practicing this, but remember there is a slight rise in prolactin level. We all know that prolactin level goes up in stress, it is a stress hormone. So, but that is not going to affect the outcome as far as the IVF is concerned. Now, this is another important thing which was addressed by the British Journal of Medical Practice, and there was few things that perhaps it is a concern about CA pancreas. Now, that clearly mentioned that this is not the worry as far as the hyperprolactinemia is concerned. If the patient, we cannot avoid the antipsychotic if the patient mental health is not good. So, this is the one thing that you can convey to the patient. We usually convey to the patient, because this paper addressed that issue, whether if we are going to go for that will result in CA breast or not. Now, this drug is a wonderful drug. Of course, you are all aware of that. Decades of use, type 2 diabetes mellitus, obesity, functional dyspepsia, PCOS and all that. And this paper has depicted that this also have a positive impact as far as hyperprolactinemia is concerned. And what they revealed, that metformin reduced plasma glucose level and improved insulin sensitivity, that we know that receiving oral contraceptive pill, that it's do well with the estradiol. Now, these are the indications that when you go for surgery, in this paper, they have summarized beautifully how to go. And remember, as we said earlier, prolactinomas, 40% of pituitary adenomas, prolonged conservative treatment for many years or even throughout life when it is failed to give you the result. Not all prolactinoma respond to DA therapy. Majority of them do, but we do have patients who do not respond to this. But remember that for the sufferer, the risk is 100%. Even if the risk is 0.1%, if we are dealing with that individual which comes in 0.1%, for her the risk is 100%. So that's important. Severity of the side effect, if patient cannot tolerate, we know that carb is much better, cab, but even then one has to keep in mind that sometimes side effect profile is so much so that patients' activities of daily living are being affected, and in this scenario you have left with no option other than to go for surgery. Tumor resistance to therapy and complications, sometimes hemorrhage in the tumors. So these are the instances where you go for the surgery. Now, what I would like to summarize here, that is a patient present, I just summarized my talk, that a problem concerned with subfertility, infertility, patient end up write a detailed history, especially the number of drugs which the patient is taking, very, very important. He has to have a normal functioning liver and kidney, not to throwing the level of prolactin high. Once we are go through it, then our investigation should be aimed as prescribed. And at present, majority of the patient, they usually respond to the drug treatment, and surgery is reserved for those people who are indicated here. A problem which can easily be handled and very significant, as I show you in the evidence. I thank you very much for your patient listening. Am I allowed to leave the stage, sir? Thank you.
Thank you, Professor Jamel Ahmed, for sharing this informative talk with us. Now I'd like to invite my next speaker, Dr. Shamila Ijaz. She is an extensive clinical and teaching experience, currently serving as an associate professor at Fatima Jinnah Medical College, Lahore, and a consultant gynecologist and fertility specialist at Concept Fertility Center, Lahore. Please come and talk about thyroid disorder and infertility.
Assalamu alaikum. I am Dr. Shamila Ijaz Munir, Head of Gynae Unit for Fatima Jinnah Medical College, Lahore. And I must thank Dr. Sadia Paul for giving me this opportunity of coming here and sharing my stage with my mentors and my teachers. And also, I must congratulate her on exhibiting such a marvelous show. Since morning, we have been listening to such a wonderful topics and need of the hour talks. So, coming to my topic. Thyroid is a very important endocrine in our body, and its disorders affect women at any stage of her reproductive cycle. Its disorder can cause increased early pregnancy loss. It can cause reduced chances of conception, and when it's untreated in pregnancy, it has dire consequences of miscarriage and neonatal abnormalities. Now, coming to an overview of So, we just have an overview of endocrine system. Basically, in our body, there are two types of mechanisms which control its metabolism, nervous system and endocrine system. Nervous system act by nerves, but the endocrine system act by endocrine glands. And thyroid is one of them. So it secretes hormones which act throughout the body to control metabolism, reproduction, growth, and development. There are some organs which secrete hormones, but they are not endocrine glands, like stomach, liver. Now, thyroid gland is the biggest endocrine gland in our body. It weighs nearly 15 to 20 grams, and it is located in front of our neck. It is butterfly in shape. It has right and left lobes, and it is a very hollow organ. It is made up of follicles which are lined by cuboidal epithelium, and they secrete thyroid hormones, which is thyroxine and triiodothyronine. So any disorder which will cause reduce in their secretion will result in hypothyroidism, like goiter and myxedema, and which increases the secretion of thyroid hormones will called hyperthyroidism. So these are quickly we will go through the functions of thyroid hormone, why it's so important. Because it has effect on all of the body systems. It promotes oxygen, so basically the BMR of our body is dependent upon normal levels of thyroid hormones. It increases use of glucose, and also it increases synthesis and breakdown of proteins. Then increase cardiac output by increasing heart rate and contractility. It increases secretion of digestive juices, and important for skeletal maturation and brain development of the fetus. So you can see from head to toe, we are dependent upon thyroid hormone. Coming to the normal values of thyroid. So TSH, which is thyroid stimulating hormone, is 0.45 to 4.12 milli-international unit per liter. And free T4, 9 to 25 picomole per liter, and free T3, 3.5 to 7.8 nanomole per liter. These are the normal values. Thyroid gland has unique ability to store its hormones inside it. So whenever there is decrease in T3 or T4, there is back regulation which increases TSH. So TSH increases, but still T3, T4 will not fall, because the stored hormones will be coming out in the system. And that stage is called subclinical hypothyroidism. And vice versa will happen with hyperthyroidism. So basically there is decrease in production of the hormone. New hormone is not forming, but the stored hormone is there. And that's why we will not see any fall in T3 and T4. So thyroid diseases can be classified according to either the hormones or by the pathology or abnormality which is there. So if we see the hormonal levels, it is hypothyroidism and hyperthyroidism. But if we see the structural and pathological abnormalities, then it's thyroiditis, goiter, or thyroid cancers. Coming to the classification of hypothyroidism. Based on location of origin, it is primary, secondary, and tertiary. So secretion of the thyroid hormones from thyroid is dependent upon hypothalamic pituitary axis. If there is something wrong in the thyroid, then it will be primary origin. If the abnormality is in the pituitary, then it's secondary hypothyroidism. And if abnormality is in the hypothalamus, then it's tertiary hypothyroid. Based on duration, it could be chronic and it could be transient. And then based on the hormone level, it could be clinical, overt, or subclinical. These are the common causes of primary hypothyroidism: iodine deficiency and autoimmune. So mostly these are the causes of hypothyroidism which we see clinically. Then hypothyroidism during pregnancy, congenital hypothyroidism, surgical removal of thyroid tissue, infiltration, and then drugs. Secondary hypothyroidism, if there is pituitary adenoma, which can cause destruction, or surgically it is removed. And then tertiary hypothyroidism, if hypothalamic diseases or trauma and tumors, irradiation, inflammation is there. So why it is necessary to treat hypothyroidism? Because of the long-term complication of hypothyroidism. If untreated, it can cause cardiovascular problems, it can lead to the myxedema coma, it can cause psychiatric and neurological complications, and in pregnancy and fetal complication are also there, which we will see in detail. So incidence of hypothyroidism, females are more common than male, 2% women compared to 0.2% male, and in subclinical, 6 to 8% women as compared to 3% male. And 2.5% of pregnant women develop hypothyroidism. So it's important to see hypothyroidism in women of reproductive age because it is the most common endocrine abnormality which we come across in pregnancy, and Pakistan it's after diabetes, of course. And in Pakistan, it is considered at a risk area. So multiple studies conducted by WHO and UNICEF during the last couple of years presented an alarming picture of iodine deficiency disorder in the area. Autoimmune thyroid disease is the most common cause of hypothyroidism in women of reproductive age. And thyroid autoantibodies are present in most of the patients, especially the Hashimoto's thyroiditis, 2/3 of those with postpartum thyroiditis, and 3/4 of those with Graves' disease. And these patients who are subfertile with autoantibodies, their treatment is basically the debate because some clinicians would like to treat them and some would not like to treat them. Why hypothyroidism is common in pregnancy? Maybe because in first 12 weeks, fetus is completely dependent upon the maternal thyroxine. So it utilizes maternal thyroxine. And secondly, the urinary excretion of thyroxine is increased in some women during pregnancy. Then serum beta-HCG structurally is similar to TSH, and it causes negative inhibition of TSH, which lowers the T3 and T4. So maybe these are the causes of hypothyroidism in pregnancy, and its prevalence is 0.5% of women, and subclinical is 2.5%. It's difficult to diagnose hypothyroidism in pregnancy because symptoms overlap. So symptoms of fatigue, constipation, weight gain, and fluid retention are there in both diseases. So it's important to see or look for those symptoms which are not common to pregnancy, like hair loss or dry skin, brittle nails, and bradycardia. Currently, there are no recommendations to do screening in general population for subclinical hypothyroidism. And there is a risk that we are missing 1/3 of the patients who will benefit with the treatment. So currently, we only do screening in those patients who are at high risk, like patients which can have any of these history. We do screening in them whether they have subclinical hypothyroidism or not. So what will happen if we don't treat? The complication of hypothyroidism in pregnancy, it can cause gestational hypertension, maternal anemia, myopathy, congestive heart failure even, preeclampsia, placental abnormalities, postpartum bleeding, preterm labor, increased rate of abortion. So you can see it has dire consequences. And fetal complications of low birth weight, fetal distress, congenital malformation, poor vision, and impaired intellect. Psychiatric and neurological complications are also there. Now, postpartum hypothyroidism, its incidence is 5 to 10%. In some women, it's transient and it recovers, but 20% do develop prolonged or chronic hypothyroidism. So women at risk of developing postpartum hypothyroidism are those who are having autoimmune disorders, positive anti-thyroid antibodies, previous thyroid dysfunction, history of previous postpartum thyroiditis, or family history of thyroid disease. And there are two phases of postpartum hypothyroidism. First, there is thyrotoxicosis, which lasts for 4 months, and after that, there is stage of hypothyroidism, which can extend up till 12 months, and then recovery starts. But as I said, in 20%, it will remain there. Now, American Thyroid Association has given us a trimester-specific TSH ranges. So if a woman is diagnosed of having hypothyroidism, she is on treatment, our aim should be to keep her TSH on these recommended levels. In first trimester, it should be between 0.1 to 2.5, in second, 0.2 to 3, and in third trimester, between 0.3 to 3 milli international unit per liter. Now, it's good if we have our own reference ranges, but if our local reference ranges are not available, then these can be used. And total thyroxine or free thyroxine, both can be used. Now, management of hypothyroidism in pregnancy, what should we do? Women who are already on levothyroxine, the dose should be increased by 25 microgram daily. Thyroid function should be monitored every 4 to 6 weeks. And the aim is to keep TSH between 0.5 to 2.5. Women who are euthyroid with autoimmune thyroid disease should have thyroid function checked every 4 weeks. So we should have close eye on them because they are at risk of developing hypothyroidism. They are euthyroid for the moment, but later on they can develop. So we have to do their thyroid function test every 4 weekly. And then following delivery, thyroid function quickly returns to pre-pregnancy levels. So levothyroxine therapy can therefore be changed to pre-pregnancy doses. But thyroid function test should be once checked after 6 to 8 weeks of delivery. Now, coming to hypothyroidism in infertility and in a gynecological setup. Hypothyroidism is associated with menstrual disturbances. A recent study has claimed that in patients with hypothyroidism, 23% had menstrual irregularities compared to 8% in normal subject. And also in infertility, we have seen that it is more common as compared to normal population. In males, hypothyroidism affects sperm morphology, decreases libido, causes erectile dysfunctions and oligospermia, while in female, it is associated with decreased libido, failure of ovulation, and infertility. Now, so subclinical hypothyroidism and infertility, whom should we treat? Now, we can divide subclinical hypothyroidism into those groups which have TSH levels more than the upper limit of normal, so 4 or 4.5, and those who have levels between 2.5 and 4. So these are the normal levels, but the upper limit of normal. Subclinical hypothyroidism seems to be more common in infertile women. We, in our infertility setup, do come across with these patients. Miscarriage rates are higher among women with subclinical hypothyroidism and a TSH level of more than 4. So that's why cutoff is 2.5. Association is less clear in women with TSH levels between 2.5 and 4. So placental abruption, preterm delivery, and premature rupture of membranes are more common among women with subclinical hypothyroidism and TSH levels of more than 4. The important thing is about autoantibodies. If the woman is having TSH levels between 2.5 and 4 and are positive for autothyroid antibodies, it's better to start her on thyroxine therapy. There is no evidence that fertility or pregnancy outcome improves with levothyroxine treatment in the absence of anti-thyroid hyperperoxidase antibodies. In those women, the TSH level should be maintained below 2.5. Even if the benefit is not robust, the supplementation is associated with no harm. So this is a beautiful flow chart, which I liked. I took it from talk. This was in 2015. So they said that if you test for TSH and it is less than 2.5, then you are very happy and there is no further treatment required. And if it's more than 4.5, so this is the upper limit of normal, so of course you will have to check for antibodies and start some treatment. It is this group which is a gray area, and I think we need more studies to be done on these patients. So if the upper normal limit of TSH is there, you have to repeat the TSH and also see whether autoantibodies are present or not. If they're not present, then okay. They will be treated as low risk. But if autoantibodies are present, then it's better to start the treatment and repeat the thyroid function tests. And if pregnancy occurs, then you have to be careful to see fetal growth and be careful that there is no hypothyroidism develops there. And if the TSH level is more than 2.5, so then it's better to start the treatment and keep the TSH level below 2.5. So the take-home message, thyroid disease can have significant effect on reproduction from conception to birth. That's why it's essential to be appropriate in screening, to keep a high index of suspicion, and to manage promptly to reduce the fetal maternal side effects. The benefits of levothyroxine replacement in euthyroid women with autoimmune thyroid disease, both preconceptionally and during pregnancy, is still not clear, and it's better to do further research to confirm the benefits. Thank you.
Thank you, Dr. Shamila Ijaz, for an incredible speech regarding thyroid disorders. Now, I'd like to call Dr. Shahnaz Hussaini. She is a consultant gynecologist and fertility specialist at Concept Fertility Center, Karachi. She is the founding and the executive member of Pakistan Urogynecology Association. Please come and discuss hyperinsulinemia and metabolic disorders.
Assalamu alaikum. I know it's the end of the session. I'll try to wrap it up quickly. The topic, as you know, is metabolic syndrome and insulin resistance in subfertility. Learning objectives are to know the pathogenesis and consequences of metabolic syndrome in women with PCOS, to understand the diagnostic criteria and screening procedures for metabolic syndrome, and to learn how to manage the metabolic syndrome in women with PCOS. Pathogenesis. Metabolic syndrome is also known as insulin resistance syndrome, dysmetabolic syndrome, syndrome X, and deadly quartet. Metabolic risk factors associated with the metabolic syndrome are type 2 diabetes. There's a 5-fold higher risk, and cardiovascular disease, which has 2-fold higher risk. Underlying risk factors are abdominal obesity and insulin resistance. When first the term metabolic disorder was coined, they believed the clinical entity only had insulin resistance. But later, the diagnostic criteria for metabolic syndrome changed, as this chart shows. They say it's about central obesity. If the waist of a woman is equal to or more than 88 centimeters, that comes to 32 inches. And if there are elevated triglycerides, reduced HDL, elevated BP, and raised blood sugar, then you can call that person. I mean, even a few factors are there with central obesity, you call it metabolic disorder. Metabolic syndrome, sorry. Metabolic syndrome includes central obesity, hypertension, atherogenic dyslipidemia, and insulin resistance. And it affects 33% of women with polycystic ovary syndrome. And the consequences of metabolic syndrome include cardiovascular disease, type 2 diabetes, cancers, especially endometrial cancer, postmenopausal breast cancer, colonic cancer, and pancreatic cancer, sleep apnea, and psychological problems. Cardiometabolic risk screening involves obtaining data on smoking history, weight, body mass index, waist circumference, blood pressure. So it's actually the cardiometabolic risk of each individual is different, and it is calculated. And management of metabolic syndrome should be focused on the risk factors of that particular individual. And the Three lines on which it is managed is, first is lifestyle modification, and the second line is drug therapy, and then bariatric surgery. Well, this is just a diagram to show what causes it: diet, lifestyle, aging, and sometimes genetics does have a role in it. And these are the diseases it causes: heart disease, stroke, blood sugar, degenerative joint problems, polycystic ovarian disease, memory loss, depression, cancers, GERD, respiratory diseases, and inflammatory disease, arthritis. Major factors affecting fertility is obesity. Recent findings are fertility can be negatively affected by obesity. Early onset of obesity favors the development of menstrual irregularities, chronic oligoanovulation, and infertility in the adult age. And there's increased risk of miscarriages, and that impair the outcome of obesity also impairs the outcome of assisted reproductive technologies and pregnancy, when the body, especially when the body mass index exceeds 30 kilogram per meter square. Insulin resistance and its consequent hyperinsulinemia is central to the pathogenesis of PCOS. I'll skip through it. We don't have time for that. Insulin resistance and hyperinsulinemia and early pregnancy loss. The rates of early pregnancy loss have been reported to be 30 to 50% in women with PCOS, which is threefold higher than in normal women, without PCOS. And there's a good percentage of women they have recurrent early pregnancy loss. They have PCOS. The women who are having recurrent pregnancy loss, if you look at them, a good percentage would be having PCOS. The rate of pregnancy loss with metformin treatment in a study was found to be 8.8%, which is compared to 41.9% in control group with PCOS. So with metformin treatment, when metformin treatment was given to pregnant ladies with PCOS, the early pregnancy loss was 8.8%, and the other group it was 41.9%. Metformin treatment during pregnancy in women with PCOS is safely associated with a reduction of first trimester spontaneous abortions, and it is not teratogenic, having no adverse effects on the biological and physiological conditions of the baby. I'll skip this one. Now, about the treatment, first I'll talk about the treatment of metabolic syndrome, then hyperinsulinemia. When I talk about lifestyle modifications, exercise and dietary regulations are important component of a healthy lifestyle. I'm sure you all know about it. Reduced body weight is associated with a decrease in metabolically active visceral fat, which in turn leads to decreased insulin resistance and optimized lipid profile, and may have psychological benefits such as reduced anxiety and depression. It is recommended to undertake regular exercise for 150 minutes per week, which comes to about 22 minutes per day, and 50% of which should be moderate intensity aerobic activity. And in diet, elements to be optimized in dietary goals are the quality, quantity, and spacing of the meals. Carbohydrates should be taken, but with low glycemic index. I'll tell you what low glycemic index is. They improve insulin sensitivity. Dietary fiber is indigestible part of food that causes satiety, lowers cholesterol, and slows absorption of carbohydrates. Proteins take longer to digest, hence improve the insulin profile. Monounsaturated fatty acids, they improve cholesterol and glucose levels, as well as insulin response. Example is olive oil. And very long-chain polyunsaturated fatty acids, including omega-3 and omega-6 fats. They lower the inflammatory markers like cholesterol and triglycerides, and they increase insulin sensitivity. Well, this is a typical, this is a 1,500 kilocalorie distribution in one day, a person should, having 1,500 kilocalories on a reducing regime, should have this proportion of food. That is, fat should be roughly 25 to 30%, which should have increased omega-3 fats, and it's all given here. And low glycemic index foods should be 40%, and they include bran, cereals, sweet potatoes, milk, oatmeal, and vegetables. Fiber is a good source. That 25% of the diet in a day should be of fiber. That is whole wheat, rye, or oats, and roughly 25% should contain lean protein with low fat content, like chicken, meat, fish, and yogurt. Medical management basically comprises of two drug groups. One is insulin sensitizing agents that consists of metformin and inositol, and the other group is anti-obesity agents that consists of orlistat, liraglutide, and statins. Metformin can be used in incremental doses ranging from 500 to 1,500. It's commonly associated with adverse gastrointestinal side effects, including nausea, abdominal pain, and diarrhea. To overcome that, it is advised that it should be, the dose of metformin should be gradually increased. And we have extended or slow-release metformin available in Pakistan as Metformin XR or Glucophage XR. That can be given once a day to overcome the GI upset. Inositols are compounds with insulin which are very much like insulin mimetic properties, particularly the isomers myoinositol and D-chiro-inositol are involved in downstream signaling pathways following the activation of insulin receptors and are considered mediators of insulin action. D-chiro-inositol leads to decreased basal insulin levels and improved lipid profile and reduced systolic blood pressure. Orlistat, that is anti-obesity agent, is an irreversible, we have it here by the name of Orslim or it's available in 120 milligram here. Orlistat is an irreversible gastric lipase inhibitor that prevents the breakdown of dietary fat and thus its absorption. A randomized study on the effect of orlistat on obese women with metabolic syndrome demonstrated reversal of metabolic syndrome in 43.5% of participants with associated significant improvement in anthropometry, insulin resistance, lipid profile, and blood pressure. Dose is 60 to 360 milligram orlistat per day. Since we get 120 milligram capsules, thrice a day makes it 360 in divided doses before meals. Its use is associated with mild to moderate gastrointestinal side effects, including steatorrhea, abdominal pain, which potentially affects compliance to treatment. Patients sometimes complain about having greasy stools and they don't like it. It is contraindicated in pregnancy and lactation. There's another obesity-lowering drug, liraglutide. It's a glucagon-like peptide receptor agonist, including it's an approved anti-obesity agent. Administration of liraglutide is associated with a significant reduction in BMI, but but its use is limited because because by the need of parental administration. It can't be taken oral. So sometimes people object on the parental administration. Statins, it's only used in women with dyslipidemia, and the use of statins result in significantly and consistently improved lipid profiles. Although there appear to be multiple options for the pharmacological correction of metabolic derangements in women with PCOS, no drug is currently recommended as a standard line of management. The apparent benefits of medical therapy must be weighed against the risk of potential adverse effects of prolonged treatment. Surgical management. Bariatric surgery may be offered to individuals with class 3 obesity. That is when the BMI is equal to or more than 40 kilograms per meter square. Women undergoing bariatric surgery have demonstrated reduced cardiometabolic risk factors, and they're reflected by an improved lipid profile and reduced insulin resistance. Common bariatric procedures include laparoscopic adjustable gastric banding, vertical banded gastroplasty, and Roxanne gastric bypass. I've had a few patients who were pregnant after bariatric surgery. You know, and there was no problem in the pregnancy, etc. These procedures have been found to be beneficial in reducing cardiovascular events, inducing remission of type 2 diabetes, hypertension, obstructive sleep apnea, and subsidence of metabolic syndrome. Now, insulin resistance and the treatment of insulin resistance and metabolic syndrome, it has some overlap in it. I'm going to talk about the treatment of insulin resistance now. Most women with PCOS suffer from insulin resistance and compensatory hyperinsulinemia. Suggests that the elevated circulating insulin concentration impedes ovulation. Insulin resistance is commonly defined by the decreased ability of insulin to stimulate glucose disposal to target tissues. Numerous studies have documented that both lean and obese women with PCOS are insulin resistant. For the sake of completion, ovarian hypoandrogenism, it's driven primarily by luteinizing hormone LH. In the overweight, insulin may augment the effects of LH by amplifying the secretion of androgen by the ovaries. Insulin also suppresses the secretion of sex hormone binding globulin by the liver, leading to increased levels of free circulating testosterone. Now, the role of insulin sensitizing drugs for in vitro fertilization, it was reported as an abstract at the 1999 meeting of the American Society of Reproductive Medicine that metformin treatment increased the number of mature oocytes retrieved from women with PCOS undergoing IVF and embryo transfer, and ICSI. Metformin treatment significantly increased the number of mature oocytes, fertilization rates, and number of embryos produced. Okay. And effect of insulin sensitizing drugs and on early pregnancy losses. Hyperinsulinemia has been implicated as an independent risk factor for early pregnancy loss. Insulin resistance has been shown to decrease the circulating glycodelin and insulin-like growth factor binding protein 1 concentrations, factors that may be important for establishment and maintenance of pregnancy. Metformin inhibits the production of, I think this is a repetition, hepatic glucose, decreases lipid synthesis, increases fatty acid oxidation, and inhibits gluconeogenesis, resulting in a decrease in circulating insulin and glucose. It enhances insulin sensitivity at the cellular level as well. Most studies or case reports of metformin demonstrated that metformin administered at a dose of 500 milligrams 3 times a day, that is 1500 milligrams daily. It increases menstrual cyclicity, improves spontaneous ovulations, and promotes fertility. It causes reduction in miscarriage in women with PCOS who are treated with metformin throughout the pregnancy. Now, talking about D-chiro-inositol is a novel insulin sensitizing drug. It has been demonstrated in a randomized double-blind and placebo-controlled trial to increase the frequency of ovulation in obese women with PCOS. Conclusion, despite its high prevalence, metabolic syndrome is a neglected entity. Timely recognition, prevention, and treatment is key to the management, and the treatment should be individualized. These are the references. Thanks for your patient listening. I know it was the last talk, so I just hurried. Thank you.
Thank you, Dr. Shahnaz Hussaini. Thank you all respected chairpersons, speakers, and honorable guests who attended today's session and shared their knowledge and experiences with us. Now, our inaugural ceremony should be started at Marquee at 7 p.m. sharp. Kindly be seated there. Thank you.